industry. Please enjoy the stimulating talk, discussion and networking over the next 3 days. Thank you very much.
Vijayalakshmi, Professor Anurag Kumar and Mr. Chris, a warm welcome. Now I would like to introduce the chair for session 1 of the conference. Dr. P. Satish Chandra is a neurologist of NIMHANS, National Institute of Mental Health and Science. His areas of work include epilepsy, neurology and neuroinfections, including neuro-AIDS. He is known for his contributions for the Epilepsy Control Program in India. He is a recipient of Asia-Oceanian Improvement Award in Epilepsy and the WHO sponsored International Neurosciences Fellowship, among many other laurels. So I would like to invite Dr. Satish Chandra to chair this session. Thank you.
Good morning. Professor Anurag Kumar, Director IISc, Sir Vijayalakshmi Ravindranath, faculty and friends. It is a great day that the first conference of this nature is being held in the Center for Brain Research, thanks to Mr. Chris Gopalakrishnan's contribution to this institute. And we are looking at dementia in the midst of our changing demography in the country. The demography has totally changed, and now we are heading towards the older age. That means we are graying very fast in this country too, similar to the Western country. At this juncture, this neurodegenerative disorders play a very important role, and that's why we are having a conference from the Center for Brain Research. To start with the first session, we have speakers from all over the world. I have a great pleasure in, thanks to Dr. Vijayalakshmi Ravindranath. The first speaker today, John C. Morris. I don't think he needs any introduction to this august audience. He is the and as my Hacker Friedman Distinguished Professor. We always talk about Professor of Neurology. Here is who is a Professor of Neurology, Professor of Pathology, Professor of Physical Therapy, Professor of Occupational Therapy, and Director of the Charles F. Jones Knight Alzheimer's Disease Research Center at Washington University in St. Louis. So, and he has more than 50 papers to contribute to the scientific literature, extensively in the field of dementia, and this audience who is very much interested in the field of dementia and cognition requires much more information on Stalwart, who is working and a genius in this area. He received number of awards. If I start in the list of that award, I think I may take 1 hour. So, short at the stage and request John C. Morris on can Alzheimer's disease dementia be prevented?
Very gracious introduction. I the opportunity to be in Bangalore, and a real honor to lead off the first international conference on neurodegenerative diseases sponsored by the Center for Brain Research here at the Indian Institute of Science. It's a tremendous pleasure to have been here and to meet everyone associated with the Center for Brain Research. And I think I've been chosen to give the first presentation. After this, the quality only goes up. So, this is the faculty and staff at Knight Alzheimer's Disease Research Center at Washington University in St. Louis. I'm very privileged to be able to direct this really talented group of individuals. We're supported by many departments at the university, and we follow somewhere over 900 volunteer participants each year. So everyone, I believe, in Alzheimer's disease knows these basic facts. This is the first known Alzheimer's patient. Clearly, others had Alzheimer's disease prior to her diagnosis in 1906 by Professor Alwas Alzheimer. It was never recognized that it was a brain disorder characterized from these photomicrographs from Professor Alzheimer of the amyloid plaques and the neurofibrillary tangles that he so importantly described, and with more modern immunochemistry, we see the microscopic amyloid plaques and the neurofibrillary tangles, and we know that the plaques are become dysregulated and insoluble deposits of the brain protein amyloid beta, and the tangles are made up of misfolded brain protein tau. But the ultimate result of these brain lesions is that neurons, brain cells, die, and with death, of course, the brain becomes atrophic. We see the atrophy here in a hemibrain of someone who died of Alzheimer's in comparison with a similarly aged person who did not have Alzheimer's disease, the marked brain atrophy and the corresponding increase in the ventricular and sulcal spaces of the brain. So this is the disease. As we heard, becoming a world health epidemic because of the relentless aging of societies. This is a strongly age-associated disorder. So this is the way I view Alzheimer's disease. I see it as a pathobiologic term. It indicates that there is a process of neuronal and synaptic loss that is a continuous process of synaptic and neuronal deterioration regardless of the clinical status of the affected individual. So that means there are really two major stages of the illness. One, an asymptomatic stage, clinically silent, in which the brain disorder has begun, but there are as yet, no symptoms, and then eventually, once sufficient synaptic and neuronal loss has occurred, cognitive function is compromised, and we have the symptomatic phase of the disease. So most of us, when we hear the term Alzheimer's disease, we envision someone who is already clinically affected with the disorder, but in recent years we've come to recognize that perhaps the major phase of the illness is really this asymptomatic phase that we call preclinical Alzheimer's disease, because it cannot be detected by our current clinical methods. So two phases of the illness, preclinical and symptomatic. Symptomatic Alzheimer's disease, because it's caused by this continuous process, also is a continuum of cognitive decline. It begins insidiously, very difficult to appreciate early, but it always progresses, and it causes disruption of the individual's ability to carry out his or her custom activities. So clinically, we classify the illness based upon the severity of symptoms from the initial stages, incipient, prodromal, mild cognitive impairment, but it's the same underlying disease process that progresses inevitably to what we recognize as frank dementia. These are the confirmed risk factors for Alzheimer's disease. So getting older, number one, but there are genetic components. There are two rare genetic causes of Alzheimer's disease. The first is trisomy 21, Down syndrome. Essentially, all individuals with Down syndrome will develop the brain disorder of Alzheimer's disease, usually by age 40, and many become demented as well sometime about 10 or a decade or so later, by age 50. There are families, about 400 have been identified worldwide. There probably are others that have yet to be identified, in which Alzheimer's disease is caused by a pathogenic gene mutation in one of three genes, the amyloid precursor protein gene, presenilin 1, and presenilin 2, and the mutation is dominant, so it's an autosomal dominant inheritance pattern in these rare families. These families represent less than 1% of all individuals who develop symptomatic Alzheimer's disease, but they're very important for understanding the underlying mechanisms of the illness. For example, that first patient with Alzheimer's disease that was identified by Professor Alzheimer in 1906 subsequently has been determined to carry a presenilin 1 mutation. So our clinical pathologic understanding of the illness from Alzheimer's initial report really comes from the study of a person who had a pathogenic mutation causing the illness. But most of the genetic contribution to Alzheimer's disease comes from a combination of susceptibility genes, the most prominent of which is apolipoprotein E, but at least 20 other gene variants probably contribute to the host and likely play a role, including other comorbid disorders, vascular disease, diabetes, lifestyle factors such as cognitive activities, physical exercise, and dietary factors. So there are a number of risk factors that have yet to be fully appreciated that likely interact with these susceptibility gene variants. So we recognize Alzheimer's disease today because it produces dementia. Certainly, Alzheimer's disease is not the only cause of dementia. There are many causes, but in late life, Alzheimer's disease is by far the most common cause of dementia. It's not, nothing about having Alzheimer's disease protects the brain from having other dementia illnesses, so it's not uncommon that Alzheimer's disease can be combined with Lewy body pathology or with vascular insults, a mixed dementia, but it is by far the most common single cause of dementia in late life. So how do clinicians recognize dementia? So this is the clinical definition of syndrome of cognitive decline. Almost all Alzheimer's disease begins with amnestic deficits that is sufficient to affect daily function. Of course, this is very difficult, as we've mentioned, in the early stages, to be certain that there has been a change in cognitive performance or that everyday function has been impaired, but we elicit history from the patient and the family members to try to ascertain this decline. We use the concept of intra-individual decline, where someone who knows the individual well tells us that there has been a change in that person's previously attained cognitive and functional abilities. Now, another way to determine this is to evaluate the individual's objective cognitive test performance with neuropsychologic testing and comparing that test performance with normative data from age and education-matched individuals. This then is inter-individual determination that is cognitive impairment. Now, this is very appropriate. We all do neuropsychologic testing, but I'm going to try to illustrate from observations from some of our research volunteers at Washington University that this is not as effective as this intra-individual change. So recognize the concept intra-individual decline. So here I show you two of our healthy control individuals in our cohort at Washington University. Here I'm showing you the factor score for all of our psychometric measures, where a score of 0 represents the mean, the average of all of our healthy controls in our program. So this would be the sum of our healthy controls are good, so they may score 1 or 2 standard deviations above the others. Some may perform less, 1 or 2 standard deviations below the others. Here I show you at this point in time the performance of 2 individuals. This is one men in the program, and he scored absolutely at the mean for all of our healthy controls. Here's a woman, and she's scoring at the lower end of healthy controls, so about 1.5 standard deviations below her peers. So what happens over time? We follow individuals annually with our clinical and cognitive assessments. Here's the future course over the next 2 years for both of these individuals. So the man has begun to decline quite dramatically, but 2 years later he's 4 standard deviations below the mean. The woman has continued her relatively performance compared to others, but has not declined. She's quite stable. This isn't the entire story. We have seen these individuals many years before the point of time that I've demonstrated here, and at baseline we can see that the man was one of our top performers, highly educated, retired, chief executive officer of a firm, and he did pretty well for about 6 years. Maybe there's a little bit of decrement, but at this point, there's almost an inflection where he's going down quite dramatically. Now, I showed you originally his test performance here, and if we had only had test performance, we would have called him normal compared to others, but he is not normal at this point from where he began. Intra-individual cognitive decline is much more sensitive than comparison to age-matched norms. The clinical diagnosis of Alzheimer's disease, even in the best of hands, is imperfect. At the Alzheimer's disease centers in the United States, we are at best accurate about 83% of the time in correctly diagnosing Alzheimer's disease during life when compared with the pathologic examination. It's because the concept of Alzheimer's dementia is a syndrome, and we haven't always been entirely accurate in applying that syndrome to individuals. Matter of fact, we're increasingly concerned in the pharmaceutical attempt to evaluate drugs for the efficacious treatment of Alzheimer's disease, that individuals who are recruited into these trials may not have Alzheimer's disease. So we may lose the power to detect a clinically meaningful effect because we've enrolled individuals who lack the illness. But in the past decade, we have increasingly seen the value of looking at molecular biomarkers of Alzheimer's disease to help us determine whether individuals actually have the brain pathology of the illness. And recent revisions of diagnostic criteria for dementia due to Alzheimer's disease have suggested that we incorporate these biomarkers to help us have greater confidence in the clinical diagnosis of the illness. The molecular biomarkers are reduced levels of amyloid beta 42 in the cerebrospinal fluid, elevated levels of CSF tau and phospho-tau in the spinal fluid, and then tracers for amyloid, and now also for tau that can be detected by PET imaging. The original tracer that was most prominent in research settings was C11 Pittsburgh compound B, but now there are F18 tracers that have been approved by the Food and Drug Administration and are much more commercially viable. We can also evaluate the consequences of molecular pathology of Alzheimer's disease by looking at the effect of that pathology, so reduced volume of brain, hippocampal volume, or reduced metabolism with FDG PET, but these are less specific for Alzheimer's disease and can be caused by other pathologies. This is to illustrate the PET imaging biomarker. This is with PIB from our center. We're looking at an axial PET image of an individual who is cognitively normal. The PET tracer, which has very high affinity for deposited amyloid beta in the cerebral cortex, is infused and perfuses through the brain. If there is no amyloid deposit, no amyloid plaque, the tracer doesn't bind to anything and is washed out, so we have a negative PET image. If the tracer finds amyloid plaques, it binds to those plaques with very high affinity. It gives off a radio signal that the PET scan can detect, as we see here with this person who has clinical diagnosis of Alzheimer's dementia, and this helps support that clinical diagnosis by indicating there's quite a large amount of amyloid plaque deposits in the brain. But we can also see this positive PET signal, this biomarker signal, in some individuals who are cognitively normal. So here's an individual who does not have any clinically detectable symptoms of Alzheimer's dementia, but has a PET PIB scan that shows a high amyloid burden, almost identical to the person with clinically expressed Alzheimer's disease. So we would say that this represents an individual in that clinically silent stage, the preclinical stage of Alzheimer's disease, and we would hypothesize that this person is at increased risk, if they continue to live, of becoming symptomatic with the illness. And that's exactly what happened with this individual. 3 years later, they had the symptoms of Alzheimer's disease dementia. So now we can detect Alzheimer's pathology in individuals who have the symptomatic illness, but we can also extend it to identify individuals who are still cognitively normal but have the brain pathology of Alzheimer's disease. We can do this with PET tracers for amyloid, and currently now we're testing PET tracers for tau. We can do this also with cerebral spinal fluid levels of amyloid beta 42 and phospho-tau. Using PET imaging, again at our sample at Washington University, we see that preclinical Alzheimer's disease may begin in some individuals as young as the 6th decade of life, in the 50s. Some individuals already have amyloid plaques in the brain. And it increases as a function of both age and ApoE4 status, such that by age 75, somewhere between 25 and 30% of cognitively normal older adults are amyloid positive. And again, the hypothesis is if these individuals continue to live, they will become symptomatic. Whether they all do become symptomatic, it's inevitable, or at how long it will take are questions still to be resolved. I turn now to the track record of clinical trials using what we think are mechanism-based therapies, disease-modifying therapies, since 2001 in individuals with Alzheimer's dementia, and they all to date have failed. we had no effective therapies to treat the underlying pathology of Alzheimer's disease, despite great optimism 15 years ago that we were entering the era of disease-modifying drug therapies for Alzheimer's disease. They've all failed. It's been very discouraging in the field. Most of these agents have targeted as the mechanism amyloid beta, but not all. Others have looked at cholesterol and inflammation, insulin, and none of them have shown efficacy, or they have been halted because of intolerable side effects. So it's a very, as I say, very discouraging realization that despite great hope, none of these very expensive trials have shown any benefit for patients. Now, why is that? Well, maybe the drugs are not very effective. They don't engage with their target. We don't think that's the case. Matter of fact, we have evidence that some of these anti-amyloid therapies, in fact, do demonstrate target engagement. But maybe some of the drugs do not. Another reason may be we're identifying the wrong target. Many people would take the failure of these anti-amyloid drugs to demonstrate efficacy to suggest that the amyloid hypothesis of Alzheimer's disease is incorrect. So maybe it's the wrong target. But another reason for the failure of these trials could be that the drugs have been administered too late in the disease course. So all of those trials were conducted in individuals who already had symptomatic Alzheimer's disease, from very mild clinical dementia rating of 0.5 to CDR3. And we know that individuals, even at this earliest symptomatic stage, incipient Alzheimer's disease, mild cognitive impairment due to Alzheimer's disease, that already in regions of the brain that are particularly vulnerable to the Alzheimer process, such as the entorhinal cortex and the hippocampus, that up to 60% of neurons have been lost. So by the time symptoms occur and we make the clinical diagnosis of the illness, the brain is already irreversibly damaged, at least in sensitive areas. So we may be administering the drugs too late to an already damaged brain, even at this earliest symptomatic stage. So, too late. We're giving the drugs too late. All those trials were given to people with a clinical diagnosis of symptomatic Alzheimer's disease. Another potential reason for the failure of the clinical trials to demonstrate efficacy in symptomatic Alzheimer's disease is that it's no longer a process that a monotherapy may be able to address, because there are many pathologic processes besides dysregulated amyloid beta that are ongoing. So we will have to broaden our approach to consider a cocktail of drugs, such as we do for chemotherapy for cancer individuals, combination therapy to address multiple targets. However, it's possible that monotherapy may still be beneficial in the preclinical stage of the Alzheimer's disease, which we now can identify by the utilization of those molecular biomarkers for the illness. So looking at reductions in cerebral spinal fluid amyloid beta concentrations, or targeting amyloid deposits with PET scans, or changes in the tau level in the CSF, and so forth. So the hypothesis here is that the pathology begins, for reasons yet unclear, with dysregulated amyloid, and over a period of perhaps 20 years, the pathology gradually builds in the brain, until it reaches a point where it disrupts synaptic and neuronal integrity. At that point, there's an irreversible continuum of change that leads to symptomatic Alzheimer's. But intervening with some of those anti-amyloid or other disease-modifying therapies in this preclinical stage of Alzheimer's disease might still be beneficial in delaying the onset of symptomatic disease or perhaps even preventing its occurrence. However, we're limited because we have yet to understand fully what preclinical Alzheimer's disease might entail. Here is a postulated disease course for the preclinical Alzheimer's disease, developed by working groups from the National Institute on Aging, the Alzheimer's Association, where it is postulated that the first stage of preclinical Alzheimer's disease is amyloidosis, so abnormal deposits of amyloid in the form of amyloid plaque. That is proposed as stage 1 of preclinical Alzheimer's, and we can detect that with PET imaging or CSF reduction of amyloid beta 42. Then it is postulated that the next stage would begin to interfere with neuronal integrity, so it leads to injury biomarkers, and this could be release of tau into the CSF, or it could be hypometabolism with FDG PET scans or hippocampal atrophy, some measure of neural injury. Amyloid first, neural injury second, then stage 3, and this is all hypothetical, would be amyloidosis, neural injury, and then cognitive decline that then progresses to symptomatic Alzheimer's disease, MCI, due to Alzheimer's disease, Alzheimer's dementia. So we evaluated, again, at our Alzheimer's Disease Research Center at Washington University, the consequences of this postulated course of preclinical Alzheimer's disease. And we looked at our cognitively normal individuals, over 300, all of whom have had spinal fluid examinations. And we found that the majority had no indication of amyloid or neural injury or subtle cognitive decline. They were perfectly normal. 129 met that stage. Stage 1 had indications of amyloid deposition, reduced CSF A beta 42, but no indication of injury or cognitive change. Another 36 had both amyloid as well as neural injury as determined by elevated CSF phospho-tau. And a few met criteria for stage 3, where they had amyloid, injury, and subtle cognitive decline. Another group had elevated CSF phospho-tau, but no indication of amyloid deposition. The term for this has been proposed to be suspected non-Alzheimer pathology, or SNAP. So here's what happened to these individuals in these different stages of preclinical Alzheimer's disease over a 5-year period. Did they develop symptomatic Alzheimer's disease? The good news is, if you do not have any amyloid in your brain, either your stage 0 or your SNAP, your risk of becoming symptomatic over 5 years is very low, 2% and 5%. If you have amyloid only, your risk is somewhat elevated, but not a great deal. It's when you develop amyloid plus neural injury, whether or not it's accompanied by cognitive decline, that the risk becomes clearly elevated. And extending this over a 14-year period, you can see the risk for stage 3 individuals amyloid, injury, and cognitive decline is about 80% of becoming symptomatic. If you have amyloid and neural injury, it's around 50% over this 14-year period. But if you are stage 0 or have SNAP, it's very, very limited. So this begins now to tell us people at excessive risk of becoming symptomatic, these individuals with preclinical Alzheimer's disease, we probably would not want to intervene with therapies to prevent symptomatic Alzheimer's disease in individuals who were cognitively normal without amyloid or who had amyloid only, because the risk of becoming symptomatic over this long period is quite low. So this is the stage where we're beginning to shift from treating with our disease-modifying therapies individuals with symptomatic Alzheimer's disease, and we're beginning to look now at asymptomatic individuals who have this biomarker-defined preclinical Alzheimer's disease. As we indicated, about 30% of healthy older adults have biomarker evidence of preclinical Alzheimer's, and they are at increased risk, and we're beginning to define that risk of becoming symptomatic. But from an individual standpoint, we're still unable to predict whether everyone will progress to symptomatic Alzheimer's, and we still are unable to predict when they will, if they do become symptomatic, how many years it will take for them to do so. But there is a group of individuals that addresses these limitations, and that is the individuals who have dominantly inherited Alzheimer's disease, autosomal dominant Alzheimer's. Very rare, less than 1% of all of Alzheimer's disease is caused by the autosomal dominant form of the illness, but all of these individuals with nearly 100% penetrance are destined to become symptomatic, and we can predict with reasonable accuracy when they will become symptomatic based upon when their affected parent became symptomatic. The problem is, it's very rare. So how are we going to study this very potentially informative group of individuals? So in 2008, we were very pleased that the National Institute on Aging of our National Institutes of Health awarded a large cooperative agreement to Washington University to form something called the Dominantly Inherited Alzheimer Network. This is an international study of academic centers who have experience with this rare form of inherited Alzheimer's disease, to all evaluate their individuals in a uniform manner using standardized instruments so that all the data can be pooled in a central data repository. And we decided that we would focus on the asymptomatic form of the disease, so individuals who inherited a mutation but have yet to develop the symptoms of Alzheimer's disease, to try to look with intensive biomarker assessments over time to determine when the pathobiology of Alzheimer's disease begins in those asymptomatic carriers compared to when we expect them to develop the symptoms of the disease, determine the sequence and the rate of those changes longitudinally, and then compare the phenotypes of this dominantly inherited form of Alzheimer's disease with late Alzheimer's disease to see how much of what we learn, this very singular group of individuals, may translate to this much more common form of the illness. So we originally set out to enroll, study longitudinally 400 individuals. Because of the dominant inheritance pattern, we expected that we would enroll about 200 mutation carriers, but also 200 non-carriers. The reason for this, even though we're focused on the asymptomatic mutation carriers, is the majority of individuals from these families do not know their own mutation status, nor do they wish to know. the DIAN study makes available genetic testing. If a person does want to know their mutation status, this grant pays for individual genetic testing, but the majority of people decline that. They don't want to know their status. So if we only enrolled mutation carriers, we would be telling them that you're positive for the illness. So we enroll everyone from a family in which we know there's a mutation, but that means we bring in some non-carriers. And this is actually a very special control group, because other than the fact that these siblings who lack the mutation, otherwise they're perfect controls. They share the same other family characteristics, genetic profiles, environmental profiles, so they serve as an excellent control group. We must find for an individual to be eligible to enroll in this DIAN study that someone, first-degree relative, has a known mutation causing Alzheimer's disease. So I'm sorry for the detailed organizational chart here, but I wanted to demonstrate that the DIAN study has been centered at Washington University. Until July of this year, I was the principal investigator, but now my colleague, Randy Bateman, is the principal investigator, and I've changed responsibilities. Randy was the clinical core leader, and now I'm taking over the clinical core responsibilities, and I've come to recognize since July that I got the worst of the deal. This is a lot of work. I tried to get back to be the PI, but Randy won't give it up. But we have clinical, biostatistics, neuropathology, biomarker, genetics, imaging, and informatics cores. Whenever possible, we try to use instruments and protocols that are already widely adopted in the field. So we base our imaging on the ADNI protocols, both for PET and for MR. And we utilize the National Cell Repository for Alzheimer's disease for our genetic analyses. And we have a remarkable group of centers. I know you can't read them, throughout the United States, United Kingdom, Australia, and now in Germany. And as of this month, also in Buenos Aires in Argentina. We're also looking to qualify sites in Korea, Japan, and China. Just note here that Colin Masters, who's here with us, heads the DIAN site at the University of Melbourne in Australia. So each of these sites enrolls individuals for the DIAN study. As I mentioned, it's a very comprehensive protocol. I'll show you in just a moment. But they all do so in an entirely uniform manner, so both the clinical, imaging, and biofluid data are standard throughout the organization. So here are the participant entry characteristics as of the end of June of this year. We've exceeded our goal. Most of the individuals are asymptomatic. We did enroll some individuals who already are affected with the disease, symptomatic disease, because you'll remember that one of our goals is to compare the clinical and pathologic phenotypes of this form of Alzheimer's disease with late onset Alzheimer's disease. So we wanted some people who already were symptomatic with the illness. Within the asymptomatic individuals, and it's about, not quite 50, but close to a 50-50 distribution between people who are mutation positive, mutation carriers versus the non-carriers. Their parental age at onset also is about 47 to 49 years of age. So this is young onset Alzheimer's disease. Here is the protocol. The participants go through this assessment at baseline. Now every 2 to 3 years thereafter. None of the participants, very few of the participants live in the city where a performance site is located. So we bring them in along with a study partner for a 3 or 4 day visit so they can undergo all of these procedures at the single time. They have a full cognitive battery, certainly blood for genetics, structural MR. We've been using PET-PIB. We do FDG PET, but we're converting this PET now to PET-tau and lumbar puncture to obtain CSF. And across the study, I just point out very high completion rates at both baseline and at follow-up for all of these procedures. This is because, one, it's important to understand the biomarker changes over time in this group, but also because the individuals who are participating are very well aware of their family history. They know that generations have been affected by this disorder, and they're highly dedicated to participating in research that may give information as to how a disorder might be better recognized and eventually better treated. So they're very committed to the cause. A number of publications have come out from the DIAN study already, including one led by Randy Bateman that characterized the clinical and biomarker changes in asymptomatic period of Alzheimer's disease. I've summarized those data to indicate that the first marker that there is a change in the biomarker status of asymptomatic mutation carriers is a reduction in CSF A-beta 42 that occurs at least 20 years prior to the estimated age at onset of the symptoms. So now we can see the pathochronology of biomarker changes prior to symptomatic onset in these asymptomatic carriers. So at least 20 years prior to the estimated age of onset. So remember, on average, the age of onset is somewhere between 45 and 49 years. That means changes are beginning at age 25 to 29 for these individuals on average. The next is to demonstrate increased binding on PET scan and evidence of neuronal injury by elevated CSF tau or reduced volume in the hippocampus. FDG PET changes somewhat later. We begin to see subtle changes in episodic memory and then clinically expressed Alzheimer's dementia. So now we're beginning to characterize this asymptomatic in this, including substantial support from the National Institute on Aging. So, secondary prevention trial in asymptomatic individuals began in December 2012 in the DIAN trials unit, enrolling asymptomatic individuals who will be randomized to one of two drugs, solanezumab, an antibody that targets the soluble form of A-beta, or gantenerumab, an antibody that targets the fibrillar form of A-beta, or placebo. I'll show that in just a moment. And the idea is to look at a biomarker outcome. Which of these drugs has the greatest effect on the biomarker? For solanezumab, it will be the concentrations of CSF A-beta. For gantenerumab, it will be the and the idea then is the drug that has the greatest target engagement will then be extended into a 4-year cognitive outcome study to see if cognition is better maintained in those who are administered the active drug compared to the placebo. Because this is a very powerful group, the sample size is not large. Again, 210 participants. We anticipate that 138 of these 210 participants will be mutation carriers. Again, we enroll some because they're accepted into the study that they must have the mutation. We enroll some non-carriers, all of whom are randomized to the placebo group. But the mutation carriers have a 3-to-1 randomization to either one of the two active drugs versus a pooled placebo group. Enrollment in this first phase of the study has completed as of November of 2015. So in less than 3 years, the enrollment is completed. And we have the trial sites listed here, and others are interested in joining. For anyone who is interested in the Diane Trials Unit study, I give the web information. This is an expanded registry for people who come from families with dominantly inherited Alzheimer's but are not enrolled in the Diane observational study, but would be interested in trial participation if that were available to them. Now, Diane, although, again, was the first to inaugurate secondary prevention trials in asymptomatic individuals, is not the only secondary prevention trial that is ongoing. Our colleagues at Banner Health Institute in Phoenix, Arizona, are coordinating with Francisco Lopera from the University of Antioquia in Colombia, South America, to do a very similar study in dominantly inherited Alzheimer's disease, but in a single family, the largest known family with a presenilin 1 mutation. And they're enrolling 200 mutation carriers, 100 non-carriers, and using another anti-amyloid antibody. The Tomorrow study, a collaboration between Takeda Pharmaceuticals and Zinfandel Pharmaceuticals, is looking worldwide at a large number, I think it's been reduced now to 3,000, cognitively normal individuals with increased risk for Alzheimer's disease based upon susceptibility gene variants, and they're using as their active agents pioglitazone. And then also in the United States has been launched something called the Anti-Amyloid and Asymptomatic Alzheimer's Disease Study, and this is not in individuals defined upon their risk for symptomatic Alzheimer's disease based upon their genetic analysis. It's based upon biomarker analysis. They all get an amyloid PET scan, and those who are amyloid positive, cognitively normal individuals between 65 and 85 are eligible to enroll in the study on a 1-to-1 basis of solanezumab, the anti-amyloid soluble drug. So secondary prevention trials have begun, and I think they give the opportunity to determine whether intervening prior to substantial brain damage will allow us to be more effective in our treatment of Alzheimer's disease in terms of symptomatic Alzheimer's disease prevention. So I will stop there, and I thank you for your attention. If there are questions, I'd be happy to take them.
Questions? Very brief, quick questions.
You did make a distinctive difference between the male and the female, the way they responded to the disease progression in the large-scale study which you have performed. So did you notice there is a difference between male and female in responding to the drugs?
In the Diane study, we have not, so the question has to do, are males or men and women different in their disease progression? To date, we have not seen that in the Diane study. In late onset disease, it may be different, but in this early onset disease, we have not seen a difference. Thank you for the question. Yes, ma'am.
So, what about your view on...
I'm sorry, how effective is what?
We've heard minocycline, the tetracycline drug.
Minocycline? I don't know.
Right? Because we've come across some papers that minocycline is effective as a...
I'm sorry, I can't answer that.
In your list. Second question is, what is the efficacy of or the effectiveness of olfaction as a preclinical symptom?
Thank you. So the question has to do, can disturbed olfaction be a
Right.
marker for this
As a marker.
preclinical Alzheimer's disease? A number of investigators have suggested that disturbed olfaction is a part of the Alzheimer pathology. I'm unaware that it is sensitive and specific enough to be termed a marker for preclinical Alzheimer's disease, but I certainly think there are people who might be more in favor of testing olfaction. We have not done that, but thank you so much.
Yes, it wasn't clear to me why you're not using the PET scan for the two different drugs that you're testing. Why not using the same outcome for the
Yes, so we just didn't want to use the same target outcome for the original design. We wanted, now, I probably should have showed you that we are testing PET PIB as a secondary outcome. So it will be evaluated. And here we're testing CSF beta 42. So, but the primary, we just decided to do it different. Thank you very much.
Thank you, Professor Morris, and this is wonderful lecture we had, and this will be followed by the next lecture.